Welcome to week 13 of this course, and this week we're going to look at the electronic health record, high-tech, and meaningful use. We've discussed meaningful use a little bit before this week, but these slides get a little bit more into depth on what that is. It's very important for this week that you do read over your transcripts so that you can understand more of the content and what's involved. This content is also you will see in future classes. You will see it in health information systems. You will see it in health records management. You will see it in legal aspects of health information. As I said early in the course, you have to sometimes see things many times before you can fully comprehend. And the purpose of this course was a survey of everything in healthcare delivery systems, which is a component of everything we do in HIM. So this week, those are our topics, and the functions of the health record you've already learned in health records management, and you know it's a documentation tool for patient care. It's also a communication tool. It's a legal record. It allows for billing and financial information. It's used for review for quality improvement activities, and it's an archive. It's an archive of everything that happened to that patient during their encounter. Here's the definition of the electronic health record that you can read over. And past and future. Past, our goal is to improve technology, government support, receptivity of healthcare professionals and patients. But we're going to see an increased use of electronic records. And with that increase in use, you're going to see an increase in the amount of data that's available. So we can be data rich and information poor. So we have to keep that in mind going forward, that we want good information in order to provide the best care. A patient or electronic, these are the rights. You have a right to right information that's accurate, free from error, and meaningful. It's got to be communicated to the right person at the right time so that person can then make decisions. It's got to be in the right place. If it's not accessible during that point of care, it's kind of worthless. And it's got to be the right amount of data. It's got to be appropriate information for what you need so the provider doesn't have to wade through a lot of information to get what they need to know. ARA, which we talked about, from the early 2000s, provided $19 billion for the health information technology for economic and clinical health. Now, the things that's important for this, notice down in the bottom where it says the Office of the National Coordinator. The Office of the National Coordinator did many things, but one of the things they did was develop all the standards that you've seen in this course, all the training, all the materials. It's a relatively new organization, got a fabulous website on how the electronic health records and the coordination of that is done. So it's a good resource for you. Out of this, under the ARA Act of 2009, the job purpose was to create jobs that also save jobs. But they really wanted to invest in education and training of health information professionals. They wanted to promote efficiency, and it was a big investment in healthcare. And why? To control cost and to improve quality and outcomes. So what it did, it promoted adoption of the electronic health care record by providers, and how they did that was they provided incentives called meaningful use. So meaningful use was that method, use of information to support decision-making and more effective care processes to improve outcomes and reduce cost. They also created what was called regional extension centers. Regional extension centers were developed to offer technical assistance and guidance on how to implement meaningful use. There are over 60 regional extension centers across the United States, and it promotes that nationwide health information exchange. So, for example, I was part at that time of a committee for Iowa for the implementing of Hitech and the RECs. And that's their purpose was, how to promote that health information exchange. They also talked about data capture and sharing to improve that quality, safety, and efficiency of care. One thing ARA really wanted to do was get patients involved in their care and let patients be informed of what is happening with their care. They also wanted to improve coordination among providers. They wanted to improve public health, but they also wanted to make sure that a person's privacy and security was protected. So engaging patients and family. I'm hoping that we're getting at a point in time in our delivery of healthcare systems where patients are starting to use more of these tools and becoming more informed. So patient e-acts on request, including discharge summary instructions from a hospital. Patients' access to portals so that they can get information. And then getting clinical summaries from your visits, either in a portal, in an email, however form. So for example, every time I go see my physician now for a yearly checkup or whatever, I go into my portal and I read the notes from that visit just for me to confirm that what is documented there reflects what happened. And then if I have any kind of test or screening, I can go ahead and look at that portal. And usually I get the results long before I'm informed by the physician of the results in. So if I have a question, when they call, I can get it answered. Care coordination is very important, exchanging information with other providers. Hopefully medication reconciliation to make sure you're on the right med at the right time. And then a summary of care for each transition or referral. To improve population and health, the e-submit for immunization registries has been a big part of this, so we can track immunizations and the instance of immunization, and also e-submitting of public health department of things that are happening. Now, in legal and in stats, you're going to learn that there are some diseases that are automatically transmitted to your state Department of Public Health, and then they go to the Centers for Disease Control. The use of electronic makes that surveillance faster. So if you think about it, a short while ago when there was the measles outbreak in California, think how fast that information went to the CDC and how quick the reaction was for what they needed to quarantine and what they needed to do. All of these benefits are part of ARA. Meaningful use rule, these were the dates that it was implemented, but they had different stages. The first stage was they really focused on capturing electronic data and sharing that. The second stage, then, they wanted advanced clinical processes, including patient access and exchange. The third stage, then, they're looking to see, did anything we do work and did it improve quality? So, for example, on stage one, the core objectives, things they wanted to measure, are listed here on this slide. Look at it, problem list. Are they using e-prescribing? Are they using structured lab results? What are they doing for smoking over 13? Are they doing that? Are they sending patient reminders? And stage two, they enhanced electronic health record access and quality measures. So for example, now they did this, now they want to measure it and see if it's working. So can patients view online, download, and transmit their PHI? Did they use computerized provider order entry, or CPOE, for more than 60% medications, 30% lab, and 30% radiology? I'll tell you, this has been a godsend, because it used to be if you went to provider and they had to get a medication, you got the piece of paper, you went to the pharmacist, you had to wait. Now CPOE makes for greater transmission of that data and less wait times, less errors too. Also, electronically recorded demographics of more than 80% of the patients so that it follows, and using that electronic progress report for more than 30%. So now they're measuring in stage two. Is the EHR working? What are we doing? Then in stage three, the providers now are required to report or attest, or whatever word you want to call it, any combination of 2 measures out of 5, and hospitals and critical access would report on combination 4 measures out of 6. So now if they want extra funding, they got to report on the measures that they've been collecting data on. And the focus is on outcome and improved quality care. Here are some terms for the electronic health record that you may have learned in health records management, you will learn in health information systems. But computer-based medical record, computer-based patient record, all of these. Notice how it's called many different things. Electronic medical records are the repository of patient care, and it is a legal record, which opens up a whole new domain for legal aspects. The components of an electronic record, you have your clinic record, your pharmacy, lab, admission, discharge, transfer, and your billing systems. All of those are a component of one record. You have your clinical includes your documentation, your order entry your barcode medication administration so they can track what you've had, and your electronic MAR, medication administration record. Your personal health record, that is an internet-based set of tools that allow you to access and coordinate your information. The purpose of a PHR is so that you can get self-management, exchange information, and information sharing. These are the kind of models that are in there, so be sure to read that on your transcript. The attributes of the EHR, you get enormous capability for storage in a small amount of space. You can access it through secure servers from remote sites, but you get almost instantaneous retrieval of information, thus better care. Attributes, they link the clinician to protocols, so the electronic record, not only could it have your information, but it might have a link for the best protocols for a treatment of a disease or an illness that physician can look at. Offers customized views. It's used for risk management, outcome assessment, but a more accurate capture for charging and billing. So these are some of the terms: computerized provider order entry, decision support systems, e-prescribing or ERX, and health information exchange or HIE. You have regional HIE informations or RIOs and nationwide health information. When they talk about the exchange, you will see this in every state, whether it's Iowa, no matter where you go. That is the network that exchanges your basic level of patient information among your electronic health records that are maintained by providers and healthcare providers. These are organized by agencies called Regional Health Information Organizations. If you want to know more about Iowa, just go to Regional Health Information Organizations for Iowa. Data security and confidentiality, you're going to get a lot of this in legal aspects of health information and also in health information systems. Confidentiality means that your data is not available or disclosed to any unauthorized persons or process. That's required by HIPAA. It doesn't matter what kind of record it is. Security is unauthorized access or destruction, protection, and that's how you administer it, physical and technical safeguards. This is required by HIPAA. It's enforced by the OCR, and remember earlier in this course, if you have a violation, the OCR will fine you. Maintaining security means you have a good power supply, you have a backup system, you have mirrored systems, so if you lose part of a system, you've got it duplicated somewhere else. It's off-site data storage, and you have to have a disaster recovery plan in the event that your system goes down. These are methods used to maintain confidentiality. Authentication means that the person using that record is the person who's supposed to be using that record. Okay, that's authentication. Part of that, you can use biometrics, you can use voice prints, you can use thumbprints, but some method to say this is the person using it. An audit trail tracks who's been in that record, and that's where they track unauthorized access. And if you get someone who shouldn't be where they're at, many facilities have severe penalties for that, up including dismissal. A firewall is that computer system that provides a security barrier between your system and hackers. They're usually software-based, but they can be hardware-based. But very, very important because, you know, you might want to think, who would want to hack a medical record? Medical identity theft, which you'll hear about in legal, is big business. Someone can get your information and get healthcare services under your name. Not only will you be billed for it, or tempted to be billed, but your whole personal record, anything that you have to go and fix it. And say, this is not my record, this is not me. Very, very hard to do. Encryption refers to transmission of data and protecting it, and then you got your confidentiality statements. So this is a summary of that. We did it all in one thing. Make sure you read your transcript for this week, and we'll continue on from here. Thank you.